Hello, my name is Stuart Grant, and I'm here with Kayser Enneking, who received the Gaston Labat Award in 2020. This interview is part of a series of activities surrounding the 100th anniversary of the founding of the first American Society of Regional Anesthesia in 1923 by Gaston Labat and colleagues. And although this organization, the modern-day ASRA, is not related, ASRA Pay Meds is not related. It was actually formed in 1975. It's been said that the current society would not have existed quite like it does today without the work of Dr. Labat and the original ASRA. So, Kayser, thank you very much for giving us your time and being part of this video series.
I am delighted to be here. It's always nice to get a nice conversation with you and Stuart.
So one of the things we're asking some folks a series of questions, and we're hoping to make a little memento, a little video memento series. And one of the questions I've been asking everybody is, what led you to choose regional anesthesia?
Well, there were sort of two factors. Probably the most important factor was as I was approaching my senior year of residency, I had an enormous open abdominal operation. And at that point in time, I got to use this brand new fangled device called a PCA machine. That we didn't actually have in my hospital. I had every complication of narcotics that you can have. I was either narcotized from my husband pushing the button, or I was completely miserable. And I thought, there has got to be another way to do this. And so I sort of weighed my options about whether I should do a cardiac anesthesia fellowship, which my program had sort of prepared me to do, or whether I should do a regional anesthesia fellowship, of which there were not very many at that time. And I knew that orthopedic surgeons were a lot more fun to work with than cardiac surgeons. And so, so I accepted a fellowship offer from Mercedes Concepcion. I had very big shoes to fill because Vincent Chan had been her fellow the year before. And sort of the rest is history. But Mercedes was the one who really sent me on my way.
It's a real pedigree lineage of people who she tutored a lot of folks I know and respect. There's a great list. When you obviously, I remember the time I started, we were doing subcutaneous morphine and with a few PCA devices. So I remember those days well, when newfangled PCA machines that we had more trouble with the pumps draining, and there was so many issues. But when you came through fellowship, what were the big topics and the issues in regional anesthesia as a field at the time when you started?
Oh, gosh. Was it better to do regional anesthesia or general anesthesia? It's amazing how things haven't changed. I mean, really, it's quite remarkable. I participated in a pro-con session just last year on this exact topic. And, I think it is one of the things that I have always sort of not been dogmatic about the difference between regional anesthesia and general anesthesia, but much more dogmatic about the analgesia needs to continue beyond the time that the patient hits the post-anesthesia care unit. And I think that is, and however you can get them there in a state where they are comfortable, then that is probably, and they're safe, that is probably more important than exactly which technique you use.
Yeah, and I think words of wisdom. I think being able to combine both, be able to do it and pull you out of your pocket when you need to,
Exactly.
Rather than say always one or always. I don't like the MD who says always one or the other. Yeah, and yet still it's that same question. You're right that we're talking about today. Yeah, no, plus ça change. Now, when you came out, you talked about being very few fellowships. The next question is, how did the field evolve over your career? And you've already alluded to the number of fellowships. Well, that's something that's exploded.
Exploded, and it needed to. So that's one thing, is just the number of people that are trained and are comfortable in doing regional techniques has exploded, and it's really wonderful. But particularly one thing, when I was a resident, I was trained under the adage of no paresthesia, no anesthesia. And so we, in a very crude fashion, would go looking for paresthesias. And when we got one, then we go, oh, that's great. That's where we need to put all the local. I mean, today that just seems so incredibly barbaric. And so we would do a single injection that way, risking really nerve damage for these, single injection blocks. And then you compare that to where we are today, using ultrasound guided, more often than not, continuous technique, where we can, provide days of targeted analgesia. I think that is just a completely different approach. So as opposed to a spinal is a spinal is a spinal, and we really haven't changed that a whole lot.
No, the spinal hasn't. But I would say one thing about ultrasound, which is the biggest difference from, I was trained with people who were paresthesias and then nerve stimulation. Right. Was you put the needle in and you didn't move it. Now they're putting local here, we're putting local here.
Oh yeah,
I sometimes wonder, what is safer than putting the needle and leaving, keeping it still, as opposed to, in and out. There's a great temptation to put some here, put some there, put some everywhere.
Well, I will also say that because we were so conscious of what the toxic amount of local anesthetic we could give, because we didn't really know where we were putting it. Today, I see some of my colleagues using vast amounts of local anesthetic because they have a great deal of comfort about where they're putting it, but the total volumes are pretty spectacular.
You're a real pioneer in sending people home with peripheral nerve catheters. Can you tell me any good stories about some of the first cases that you did when you sent people home?
They are sort of burned into my brain for some of them. The very first person that I did this with was a really lovely guy. And he lived about 60 miles from our surgery center. Very bright guy, good person, is Mr. B, I'll call him. And we put an axillary catheter in for his thumb suspension plasty. And we did the case on a Thursday. I called him Thursday night. I called him Friday morning. I called him Friday night. And on Saturday morning, he was to come back to the surgery center, which obviously wasn't open. And I was going to take his catheter out. And so I was waiting outside the surgery center for him to drive up on that Saturday morning. And here he comes with his axillary catheter driving up his big Cadillac. And I remember thinking to myself, oh, I didn't explain that very well. And maybe driving is one of the things we should say, no, you really shouldn't be doing that. I got to the point then where we would just talk patients of taking the catheters out while we were on the phone with them. And I remember another Saturday morning when we had put a catheter in a little 10-year-old girl who'd had a fairly extensive repair for her congenital arm, and her father was on the phone with me, and this is again about 2 days after surgery. And so the little girl hasn't had any narcotic at all, and she is running. I can hear her running around the kitchen with the father chasing her. Of course, he's tethered to the phone, right? Because the phone is on the wall, and she's screaming in the background, "No!" Just because she didn't want it to come out, because she'd had lots of surgeries and she knew what that was like when she didn't. And so I mean, you really get to know your patients in a very different way when you have that much of a relationship with them.
Yeah. Oh yeah. Phenomenally. So 2020. So you were on the board of directors of ASRA. Is that correct?
Was.
You're board director. So I take it ASRA meant a lot to you. So for many ways, you've been such a strong advocate and supporter of the society. So what was your initial reaction to news that you'd won the Labat Award?
I thought they might have gotten the wrong email address. I mean, I was, and you can see I am still a little bit stunned that I won it. When I reflected on it, I was just so deeply honored and humbled. It is just, well, one of the pinnacles of my career to have my colleagues recognize really the hard work that we did for so long, and the importance of that work. But it is, I was the one that was standing up there, but it's always a whole team, from the surgeons you work with to the nurses who help you to, all those residents and fellows. And I really felt like it was an award for sort of the improvements that we made, and sort of setting the stage for other people to do that. And maybe because we were a little bit brave in doing it first.
About chutzpah goes a long way. I was in the audience. A fantastic lecture you gave it. That was a great. And it was for me. That's the first meeting I went to after being locked in for COVID, and it was a great meeting. And that was just the cherry on the Sunday. Just your talks. That was phenomenal. But another question we've been asking everybody is like, what changes in thinking or practice or perspective do you think you've fostered during your career?
Well, I sort of alluded it before. My feeling about analgesia, and that's really what ASRA PM is about. It's making this transition between an anesthetized patient and a fully functional patient, somebody who's returned to their baseline or in a position where they can get better than what their baseline was. And, kind of the agenda that I loved about ASRA was that it was about analgesia. And there isn't any other group anywhere that is as focused on that. And I think when you're focused on that, you really are focused on keeping the patient in the middle of the conversation. And I love that about ASRA. I think that that's why most of us go into medicine. It's not to win awards or to get to be on call longer than anybody else or anything like that. We genuinely want to help people. And, Henrik Kellett, who was also a Labat Award winner, I mean, he was very instrumental in pushing us to think beyond not just the recovery room, not just those short-term goals, but really the long-term goals of we have what we do in the operating room and what we do in the perioperative period really has an enormous effect on the long-term outcomes of our patients. But we have to get ourselves out of the mindset that, whew, glad we got that patient to the PACU, I can go on to the next one now. And I think that's really been the perspective that I have tried to impart during my time in ASRA and in my time at the University of Florida.
And I think you've shown amazing leadership in that area, and the stuff you guys did packaged together was just an amazing piece of work, looking at ambulatory catheters and looking after people. I still think we're limited somewhat by the technology. 3 or 4 days is fine, but a lot of these operations, a week, 2 weeks afterwards, I still think there's a lot of work to do and a lot
Oh,
of
there
potential
is, and
improvement.
you know, that's what makes this so exciting, right?
Yeah, yeah.
Is
What's the next great thing?
that yeah, and it's going to be there.
Yeah.
I do have a small confession. When I was a resident, I was pretty sure that by this time we would be able to wheel a patient into the operating room, and we would have some kind of Bluetooth transmittal of the EKG, and we'd have some kind of blood pressure type device that we would put on the arm that would distract the nerves, and so you could operate. And so far, we haven't come up with those things.
Someday soon, maybe.
I also thought I'd go to work with a jetpack on my back. So, you know.
A jetpack. After you, I'll leave that. You
So
talked.
you got to dream big, right?
Oh yeah, oh
You
yeah.
got to dream big and know that there has got to be a better way to do this.
Oh yeah, I'm not satisfied. Yeah, keep striving.
Steps.
Yeah, keep striving. Yeah, and I'm not satisfied. I think there'll be big differences to come. Who do you look back on as your greatest mentors, who maybe installed this drive and ambition in you, let you see the big picture?
Oh, well, certainly in regional anesthesia, it was Denise Waddell. You know, there was really not anybody at the University of Florida. We were quite the little rinky-dink outpost of regional anesthesia for many, many years. And she sort of took me under my wing, under her wing, and really paved the way for lots of people. She hand edited my first paper that had gotten rejected by regional anesthesia and pain medicine, and really at every step of the way encouraged me. I will also say Terry Horlocker was one of her mentees, and I think in some ways Terry and I were like sisters competing for mom's attention. And I, you know, when I thought I just couldn't write another paper, or I just couldn't travel to another meeting and give another lecture, I'd look at Terry and she would have done twice as much as I did. And I'm like, oh boy, I got to keep going at this, you know.
So how did you and Denise Waddell meet?
It's a little bit geographic. So one of her colleagues had come to the University of Florida and was my new chair when I started, and she called him looking for somebody in Florida to help with an ASRA workshop that they were doing in Florida, and they were always trying to kind of find you know, local people. What she didn't realize is that Fort Lauderdale, where they were, is 5 hours from my house, but that was just a little bit of geography. And she asked me if I would give a workshop on lower extremity blocks. And I'm like, I was just like, oh my God, it's Denise Waddell. And so I'm like, sure, of course I can. Having only really learned how to do an ankle block during my fellowship, honestly. Everything else we did was spinals and epidurals. So I read up everything I could. At that time, most of the literature about lower extremity blocks was really out of the military. They had done lots of lower extremity blocks in the military, and there were some people in San Diego that at the military hospital there had done many of them. So I, you know, got out the anatomy books, and I had about 4 months to really kind of get ready for this, and you know, it worked great. And that sort of became my little niche, only because of that very first ASRA workshop that I did.
Phenomenal. What words? This is my last question we've been asking everybody. What words, if you could, would you choose to define ASRA pain medicine?
Well, number one, I would say supportive. And again, I think it goes, and I would say that really ASRA PM makes the patient the North Star. So it's really about not so much about, you know, who gets the academic credit for anything. It's more about how can we do the next thing to make patient care better? How can we spread the word of how to make patient care better? How can we spread the word of how to improve analgesia and function? And I believe me, I've been to lots of other, groups, and ASRA has always very much been inclusive and welcoming. And I really think it's because their main mission is all around patient care.
If that is your prime goal in healthcare, good things can happen. I totally agree. And you really echo some of the interviews done with other people. It is so reassuring and so it's heartening to hear this same message come through. And I feel exactly like you. It's one of the reasons I went to medical school was relieving pain and suffering, sort of thing. If you've got these ideals before you go, you've no idea what medical school is going to be like. You're filled with ideas and dreams. Luckily, you don't know, but
you're right.
And I think that's part of the protection that you don't know, but it's one of those ideas and ideals you have before you go. And I think this is one of those core tenets of like about being a physician and about being in healthcare is like, and I think that's what ASRA kind of means to me as well.
It's a lovely organization that is organized around a wonderful mission. And I have certainly seen the ups and downs and the ins and outs of it. And I return to it's a lovely organization with a wonderful mission.
Well, thank you so much for giving us your time this evening. I'm going to sprint back to the OR and finish off looking after that principal mission.
Thanks, Stuart, and safe travels to you.
Yes. See you. Bye-bye.
Take care.